Good morning, everybody. In the beginning, I would like to thank Professor Suresh Gupta and Dr. Sudesh Arya for making me part of this program, which is a very good program for postgraduates, and it gives them opportunity to learn so many things. In this presentation, I would just like to introduce Descemet's membrane detachment, which is a very common problem when we do the cataract surgery. And of course, it can occur with other surgeries also. If we look at the embryology or development of the cornea, we know that after lens vesicle separation, a wave of mesenchyme forms the primary corneal stroma, and then a second wave forms the endothelium, which secretes the Descemet's membrane. So there is a potential plane of separation of the Descemet's membrane from stroma. So it's always vulnerable for detachment. And also there are some genetic factors which predisposes to the detachment. If you look at the various incidences, it's common with extracapsular cataract surgery or manual small incision cataract surgery and then other surgery. But believe it, it can occur after any surgery, even after YAG capsulotomy, it can occur. These are some of the procedures where it can occur. I would just caution some of the predisposing factors. If you have recurrent herpes simplex keratitis or Fuchs endothelial dystrophy, thick Descemet's membrane is always vulnerable for detachment. If you are using blunt-tipped instruments, you are going to have it. Hypotony at the time of entry into the anterior chamber, small-sized incision. Here, I would just like to caution the beginners that your incision size should be adequate and make inner lip of the incision or inner part of the incision slightly wider. And when you are introducing your any instrument like phaco tape, make the direction little downwards. Don't make it upwards, because then there is a more risk of Descemet's membrane detachment. And always make sure that your tip of the cannula is in right place when you are injecting viscoelastic or air injection, because if it's not in the right plane, or if it is in the plane where the separation occurs, then we are going to land up with the Descemet's membrane detachment. Slit lamp examination is very important. If the corneal edema is there, you can always put hypotonic saline, or you can remove epithelium to see it, and then examine on retroillumination, which will give you more idea about the extent of Descemet's membrane detachment. Then you need detailed workup also. How much is the extent and what is there in the interface? It is clear. If you look carefully, you can always map out the extent of the Descemet's membrane detachment. Anterior segmentosity is of course very helpful. I will not go into the details of the classification of these Descemet's membrane detachment. Of course, this classification little older, but is very useful because if it is a very small Descemet's detachment and very peripheral, you can always observe it. I will show a few cases where we have managed the Descemet's membrane detachment, and we have been able to, you can see the Descemet's membrane detachment here. You can see the upper border, and you can also see the you can see that we have made the inferior paracentesis, and this Descemet's membrane was basically stuck to the posterior corneal surface. We thought we will negotiate the cannula between the cornea and the Descemet's membrane detachment and put the air bubble, and it will get lifted. But since it was stuck, so we were not able to do that. So air bubble injection was not of any use. You can see that if we press it, we can see the upper border of the detachment still there. So we remove the air bubble. You can see the upper border of the detachment just where the air bubble is there. So I was wondering that what to do for this patient on the table. So idea struck that what we should do is that we should bend the cannula and we should try to disengage the Descemet's membrane from its strictly stuck area. As you can see, the Descemet's membrane detachment still there. So for that we made the superior paracentesis, and through that we just pulled the Descemet's membrane detachment, because the Descemet's membrane has detached. So once we were putting tip of the cannula on the Descemet's membrane, it was just the stromal surface, not the endothelial side. And we disengage the Descemet's membrane from its stuck inferior border. The timing of the Descemet's membrane detachment, management, does not matter. Even if it is a long-term, chronic detachment, say after a few months. This patient was sent to me after 2 months or so. So it will. That's the reason it has got impacted. So now when I pressed, you can see that we didn't see the upper border. So this ensured that the Descemet's membrane has got detached from that the stuck area. So because the endothelial cells are in the environment where they usually are there, so we don't get so much of the Descemet's endothelial cell damage, even in the chronic cases. So once we disengaged it, we just put the air bubble, and Descemet's membrane got settled, and we had a good result. After that, we just have to put few sutures. You can see patient achieved 6/9 vision at 6/6. This case we could publish in Journal of Indian British Medical Case Reports. And there is another equally interesting case in this patient. We can see the Descemet's membrane detachment there very clearly. You can see the upper border. In this patient, the lower border is not straight. It's little rolled when we examined this patient on slit lamp. So this was interesting, that how to fix it up. So in this patient, what we have done is that we have again made the paracentesis inferiorly. Usually it's wise to make paracentesis in the area where the Descemet's membrane is attached. So after making the Descemet's that paracentesis, what I thought was that we'll put small air bubble and we'll try to unroll it to the extent where we can unroll it. And this is a very good technique which I have found. You see, we are just testing the Descemet's membrane. It's getting little unrolled. That means that the roll is free. And if we put the air bubble and push it, it can get unrolled. So once we have tested that, then we have injected a little bit of air bubble, you can see, and the Descemet's membrane is getting unrolled. We are pushing the air bubble without enlarging it. Now is the point where we are not able to push it further, and then we enlarge the air bubble so that it gets settled. So this we called the double bubble pneumodescemetopexy. You can see we did that, and it got attached. You can see there is a very small triangular area above which is still get folded, so that we settled manually, so that we can we get the finally the whole of the Descemet's membrane attached. So these were the two cases which gave us good results with these two techniques. Again, this case we published in Indian Journal of Ophthalmology. I would like to say that there are so many options we can use air. Being like now using endothelial catoplasty, we are more comfortable using with the air. We only use gases where it is very chronic or you need long-term tamponade. But I will caution that if you are using gases, be sure you may get pupillary block and you may get glaucoma, very high pressure. UVM guided repair is possible, and then anterior segment monitoring with intraoperative OCT is a very useful tool. This is our experience. We have done 23 cases and air injection in most of the cases, and we got very good anatomical success. In the end, I would like to say that prevention is always better than care. Use sharp instruments, use adequate incision size and the shape. Incision should be wider in the inner end. Direction of the tip, phaco tape or any cannula should be downward. Check the cannula position before visco injection. Any doubt, DMD, please place an air bubble. You will always see sometimes small Descemetopexy membrane detachment at the site of incision. So it's always better to avoid its enlargement and put air bubble. So in the end, I would like to say that pneumodescemetopexy is effective in most of the cases. You use air only when there is a chronic case or it fails. And I would like to say that we should consider endothelial keratoplasty only once the air injection is failed. So in the end, I would like to say that air DMD is, even in the complicated situations works. Gas should be selected for these complicated cases and endothelial keratoplasty only if it is a failed descemetopexy. Thank you so much for patient hearing.
Yeah. Thank you, Dr. Ashok. Thank you for a wonderful presentation. I think you effectively covered all the techniques and very nicely, and you have shown your publication data also. Next, I would like to invite Dr. Sudesh Arya on Bowman's membrane transplantation.